السلام عليكم ورحمة الله وبركاته. أهلا وسهلا للحضور. ما شاء الله عندنا 30 participant. اليوم هتكون جزء من سلسلة ال interventional Cardiology Lecture Series. الدكتور علي الفاندي هيتكلم على Stable Ischemic Heart Disease. دكتور علي is an interventional cardiologist من St. Joseph Hospital في لكسنتون كنتاكي. نشكر الحضور. الليكشر موجودة على الزوم، درنا لها شير على الفيسبوك اكاونت للليبيان كارديوفاسكولار سوسايتي، للليبيان كارديولوجي فورم، وعلى اليوتيوب شانل للليبيان كارديوفاسكولار سوسايتي. بالنسبة للحضور معظمهم حيكونوا ميوت، في الأخير حنخلوا أسئلة، لكن لو في أي أسئلة اكتبوهم في الشات ونحاولوا في آخر المحاضرة نناقشوها. تفضل علي.
بارك الله فيك باسم. السلام عليكم جميعا. يسعدني اليوم نكون معكم، وإن شاء الله اليوم حنغطي Stable Ischemic Heart Disease. في البداية بس نحط outline الموضوع. طبعا مش حنغطيه كله، لكن my main focus is going to be on the category of Stable Ischemic Heart Disease، ومنتكلم على presentation briefly. وبالتالي most of it I'll be talking about managing ischemic heart disease. And I think the most important part besides treatment therapies is revascularization. And I think that itself will probably need a lecture on its own. So I will probably cover a few points to that matter. Inshallah, further lectures will talk more about it. I didn't bring up a lot of data, and I think inshallah at the end of the lecture, maybe we'll have discussions about certain papers that pertain to this topic, inshallah. So for more discussion later. So stable ischemic heart disease, as you all know, coronary artery disease is a pathological process, and it's characterized by development of atherosclerotic plaque that accumulates in epicardial arteries, and it can be either obstructive or non-obstructive. The disease can be modified via multiple interventions. It can have a long course with stable periods, but it can become unstable at any time. And that's one of the important things that we should recognize about stable ischemic heart disease. And that can be due to an acute thrombotic event caused by plaque rupture or erosion. The dynamic nature of coronary artery disease process results in various clinical presentations. The presentations can be either an acute coronary syndrome, اللي هم الSTEMI and STEMI ولا unstable angina, اللي هو مش هنتكلم عليهم اليوم, or chronic coronary syndromes, which is the topic of today. فhere are other names, تسميات أخرى للchronic stable ischemic heart disease you'll hear, and the chronic stable angina, and stable ischemic heart disease, chronic coronary syndrome, and so forth. So these are all descriptions of the same category. So what's the main etiology for the symptoms of ischemic heart disease? What's the pathophysiology? So because you have a fixed blockage in an epicardial artery, because of chronic and repetitive supply and demand mismatch that is caused by increased oxygen demands, which cannot be overcome by increasing coronary blood flow, ischemia results as of that. It's usually a chronic and repetitive process of an imbalance between demand and supply. So, شنو determinants بتاع myocardial demand? عندك LV wall stress increases your myocardial demand, and the contractility, and increase in heart rate. And the determinants of myocardial supply, O2 supply, the main determinants, and the coronary blood flow, and the coronary arterial oxygen content. فأي imbalance between these two will lead to ischemia and symptoms. And that's the main pathophysiology beyond ischemic heart disease and development of ischemia. This is a very famous diagram. It's old. It's from the 2012 US guidelines about stable ischemic heart disease. And what I like about it, it just shows the spectrum of patients with coronary artery disease in general. لما تشوفوا في الفar left عندك البيشنتس اللي هم asymptomatic, patients without any history of ischemic heart disease, but they're at risk. هذول البيشنتس اللي هم leading a sedentary lifestyle, they're diabetic, they're hypertensive, smokers, you know. So all them patients that don't have a diagnosis of ischemic heart disease, but at very high risk. بالتالي عندك extreme right, to the right of the screen, عندك patients with known ischemic heart disease. So هذا the end result. The patients اللي هم نعرفهم we're dealing with right now with ischemic heart disease. فعندك in the middle, this is how these patients present. فعندك in the middle, عندك patients who come with chest pain, and then they would be either acute coronary syndromes or turn out to be non-cardiac pain. بالتالي عندك patients اللي هم categorized to be stable angina or acute coronary syndromes, and they get treated accordingly. وعندك on top اللي هم patients asymptomatic, but for certain reasons, whether symptoms or screening, they had a stress test, and then they were found to have coronary artery disease, and they're still asymptomatic, and they're treated accordingly. And then you have the unfortunate patients at the bottom of the screen, اللي هم their presentation is sudden cardiac death. And we see this a lot, where patients are undiagnosed and they suddenly present with cardiac arrest as a result of a plaque rupture. This screen in 2021 US revascularization guidelines, and it outlines the traditional risk factors for coronary artery disease. Another way to divide these is to modifiable and non-modifiable. That's another classification. To the left of the screen, عندك patients اللي هم diabetic, smokers, obese, people with sedentary lifestyle, hypertensive, and with dyslipidemia. And to the right are the other risk factors, اللي هم include psychosocial risk factors, education, employment status. Obviously, certain jobs carry higher stress levels, and therefore increases your risk for atherosclerosis and coronary events. So how do these patients present? So the classic description of angina or chest discomfort, the patients usually have retrosternal pain or discomfort, often described as constricting, suffocating, crushing, pressure light, heavy. Another common thing is radiation. So patients who have anginal pain, they usually describe radiation, more commonly in the left arm, the ulnar surface of the left arm, at times radiating to the neck or to the jaw, uncommonly to pass the jawline to the face. So it's usually below the jawline. Another common description is epigastric discomfort. And at times it can be described as heartburn. And it can be challenging at times. You know, patients are between their gastroenterologist and cardiologist. And at the end, it can be a anginal presentation. Another important presenting group of symptoms are the anginal, what we call anginal equivalents. These kind of symptoms are more common in women and diabetics. So they're not classic, but patients usually either present with shortness of breath, sometimes dizziness, fatigue, belching. So try to be cognizant in this group of patients, women and diabetics. So it's important to know how to distinguish between a stable ischemic heart disease and other presentations. So the pattern of angina is very helpful. You know, is it chronic or is it acute? There's an arbitrary cutoff for, in general, stable or unstable angina. Usually the cutoff is 2 months. So if symptoms happened within 2 months or less, we usually consider this to be unstable. Obviously, there can be people with low risk unstable and high risk unstable, depending how frequent the symptoms are. And then chronic angina itself, in general, it's repetitive, it's predictable and inducible. So patients know when they get their angina. They tell you, like, every time I do this amount of work, I get it. I have to sit down for a few minutes, and then that resolves. So that's the classic description of chronic stable angina. This is a very nice diagram that got from the European guidelines. So what it shows, on the y-axis, you have the cardiac risk, death, MI, and then you have time on the bottom. And you have here, you have three trajectories. So the bottom on green represents a patient that has lower risk factors and has been on top of his risk factors, probably seeing a cardiologist or primary care, recognized to have some coronary disease, underwent revascularization, and then underwent further control of their risk factors, whether it's blood pressure, cholesterol. And as you can see, their event rate and overall prognosis is very good. On the other hand, when you go to the line on top, which is in purple or blue, as you can see, someone who is subclinical, unrecognized, and then presents with an event, with an acute coronary syndrome, eventually gets revascularized, and then risk factors are better controlled, having follow-up, but because an event happened, the prognosis is not as good as a person who was recognized earlier before an ACS happened. And the last trajectory, which is on top, which is the worst of these three, which is a patient who has significant risk factors, not controlled, has an event that goes unrecognized, and then has a second event that is recognized, and then the attempts to control risk factors and are made, but are not tightly controlled. So as you can see, the curve keeps going up, and as you all would know, that the outcomes in this patient will not be good at all. This is a little trivia here, which I found interesting. This is Ibn Sina, or as the West call him, Avicenna. They call him the father of pre-modern medicine. So he wrote a book called the Qanun fi Tibb, or the Canon of Medicine. And the interesting thing, he described early, and this is about 1,000 years ago, he described what it sounds like atherosclerosis, although not in specific details, but he says localized accumulation of abnormal humors in vessels or other spaces may result in obstruction. And the worst obstruction is the arteries of the chief organs. And he described the heart, the brain, and the liver, which I found an interesting description from a scientist who's who lived 1,000 years ago. So this is early description, I would say, probably of coronary atherosclerosis. So this slide here just shows what we call the Canadian Cardiovascular Society classification, or CCS. What I think is important about this is it's a good way to develop a common language when you're communicating with your colleagues, other cardiologists or other physicians, is just to have an idea how symptomatic your patient is. So this is a way to communicate about how symptomatic your patient is. So patients with class 1 angina, in general, these are patients who are pretty much asymptomatic. And then you have class 2, patients who have slight limitation. Usually angina is precipitated by rapid walking or doing activity after a full stomach, full meal. And then class 3 patients are more limited. Usually angina starts within walking 1 or 2 blocks on a flat surface, or going up 1 flight of stairs. And then class 4 is where we call unstable. This is where patients start actually having pain with any activity, and sometimes even at rest. So this is a case that I'll be presenting throughout this lecture, inshallah, and we'll dissect into it and look to the patient's outcomes. So this is a 67-year-old male truck driver, past medical history of hypertension, diabetes, chronic kidney disease, and smoking, who comes to the office with complaints of shortness of breath that has been occurring frequently over the past 3 months. The shortness of breath is caused by going up a flight of stairs and walking at a fast pace. The patient is on lisinopril and metformin, and the vital signs, as you can see. And the patient's physical examination was pretty much unremarkable. The patient's EKG, as you can see on the screen, patient is in normal sinus rhythm. As you can see, upright P waves. Heart rate is in the 70s, access with a normal. And then, as you can see, he has a wide QRS complex with a left bundle branch morphology. So this is a EKG with normal sinus rhythm and underlying left bundle branch block. So in this case, what's the best next step in managing this patient? So you have a patient who presents with shortness of breath for 3 months, has multiple traditional risk factors for coronary artery disease, including age and diabetes, high blood pressure, and CKD, and active smoking. And you have a baseline abnormal EKG. So starting from the bottom, should we provide reassurance and tell him that your symptoms are non-cardiac and come back in 6 months? This probably doesn't make any sense. So we'll throw that. So next, do a right and left heart cath. This is probably too aggressive. I think we probably should start with a non-invasive test first. And there's no really indications for this right now. B, refer for an exercise treadmill stress test. So this also will not be helpful, right? Because the patient has an underlying left bundle branch block. So this stress test will not be valid. So the next best step from these options is to do an echo. You have patients who are symptomatic with an underlying left bundle. So you'll probably be looking for wall motion abnormalities or structural heart disease as a hint. So starting with the basic workup for someone who comes to you with chest pain concerning for angina or stable ischemic heart disease. So someone with no past history, so basic workup would include lipid profile to look for dyslipidemia, also screen for diabetes, check kidney functions. People with CKD are higher risk. And then cardiac biomarkers as well are helpful, especially if someone comes with acute pain, and then BNP and pro-BNP as well. That would help you to screen patients who may have underlying heart failure as a result of their ischemic heart disease. These two are also cornerstone tests for diagnosing patients with coronary artery disease, including an EKG. And in general, a stone cold normal EKG would probably indicate that the patient has a normal heart. Okay, that's not 100%, but for the most part, a completely normal EKG probably indicates a normal structural heart. Doesn't necessarily mean the patient doesn't have blockages, but at least from a structural perspective, it probably indicate that the structure is within normal. And then you have an echocardiogram as well to assess for any wall motion abnormalities that may indicate ischemia in a certain territory. Further on the theme of evaluation, so we can do stress testing, or we can do anatomical testing. Or another way to classify cardiac testing, and you can say invasive or non-invasive, but this is a non-traditional classification, and I liked it. So stress testing, our basic test that we are all familiar with is the exercise treadmill stress test. It's simple, non-invasive. You get a lot of information out of it, and I think in Libya, I think this is available everywhere. So I think this is probably one of the most important modalities for stress testing. And then you have nuclear stress tests. I don't think it's there yet. So this is a common modality that's used elsewhere. It's also a good way to stress test patients, also look for ischemia in certain territories. This is also another physiologic, or what we call functional stress test. And then you have stress echo, also an important modality, and طبعا متوفرة في ليبيا. We also have stress cardiac MRI. Not very common, even in the US. It's not a common modality, more in bigger centers. So this is not a very common stress test modality. And then we have CT-FFR after doing a coronary CT, and if there are any blockages, you can apply the CT-FFR software, and it can look into the blockages if they are significant physiologically or not. And then you have FFR, IFR, which are invasive indices with coronary angiogram. And then you have anatomical testing that looks into anatomy. So you have the basic, which is coronary artery calcium score. And then you have coronary CTA, which is playing a bigger and bigger role in the field of cardiology lately. And then last is invasive coronary angiography. This diagram was brought from the 2021 revascularization guideline. As you can see, it's a busy slide. It just shows you from top when you start with a patient with no known CAD. So you start with these patients. It's really important. You have to, in your head, when you're dealing with these patients, you have to have a risk assessment. And patients, often they're categorized, either low risk, or intermediate, or high risk. So how do we go upon these patients? So patients that are low risk. So all them patients that don't have traditional risk factors, they're younger, they have normal LVEF, symptoms are not convincing, for classic angina or classic chest pain description. In this kind of situation, what the guidelines say, no testing is recommended. If you're still on the verge or the patient does not feel comfortable, you can consider doing an exercise treadmill stress test, or the coronary artery calcium score to further risk stratify them. So these are the low risk patients. And then you have patients who are at intermediate or high risk. These are patients who are older, have risk factors, symptoms are more convincing, So in this kind of situation where you're concerned that patient may have obstructive CAD, you can go either with a coronary CTA or with a stress modality. So this goes to anatomical definition with a coronary CTA, or physiological or functional testing. And then if you go down to coronary CTA, for example, and أعتقد في Libya, this is also becoming more and more available. فعند the coronary CTA, if it becomes inconclusive. So sometimes patients have, especially older patients, it can be challenging to read their CTAs. They can have a lot of calcium, which it can obscure the coronary arteries, and at times it can come as inconclusive. In that case, you probably need to look for another modality. You're probably better off doing a stress test. Let's say the patient had a CTA and he did not have any CAD, and if no stenosis or plaque, and they're still having symptoms, then consider INOCA pathway, which is ischemia with no obstructive coronary disease. Inshallah, هنطرق شوية at the end, so we'll talk about this subset of patients. And then, what if you have a patient with non-obstructive CAD? Stenosis is described as less than 50%. في هذا الحالة في software called FFR-CT. They can actually look into it and see if it's physiologically significant or not. So let's say if the FFR-CT was significant, then in that case, if it's a single vessel, you manage with medicines and follow up. If symptoms persist, then consider coronary angiogram. Same thing for obstructive CAD, more than 50%. You can consider the FFR-CT to further look into the significance. And then going back to the stress testing, the stress test can either become inconclusive. Can a stress test inconclusive في الحالة هذه and you're still concerned, you can consider going and doing coronary angiogram. If the patient has mild ischemia on the stress test, it's safe to treat these patients with medicine and see how they do. So if they becomes asymptomatic with medicine, then you're good. Continue to follow them and see how they do. if the stress test considers, if the stress test shows you moderate to severe ischemia, okay? So in this case, they recommend, according to the new guidelines, is to optimize preventive therapies. And after that, is the patient still having symptoms? If yes, then you do invasive coronary angiography. So this part of the diagram will probably be a little controversial still, despite newer data, which we'll talk about. I'm pretty sure a lot of people are familiar with the ischemia trial. So in the ischemia trial, what they did after finding patients with moderate to severe ischemia before randomizing them, they did a coronary CTA to exclude left main disease. So it's interesting that I find here that they did not include that in this diagram. So that's something to think about. So things to think about once you diagnose a patient. Let's say a patient is diagnosed with coronary artery disease, obstructive coronary artery disease. Now you know the patient has angina from obstructive coronary artery disease. What are the things that affect prognosis or affect survival on the long term? One of the most important things is LV function. The patients اللي هم lower LV function, اللي عندهم severe LV dysfunction, they don't do well over time, and this affects survival and prognosis. Another thing is the anatomic extent. Yani how severe is the CAD? Is it multivessel? Is it multivessel and left main involvement? Is it multivessel with proximal LAD involvement? So these are so the more blockages, obviously, in general, even with older data, the more blockages, the more area at risk of an ischemia, the worse patients do overall and over time. Another important thing is the presence of a recent plaque rupture. So patients اللي هم عندهم recent ACS, يعني patient كيف يعني عنده MI, STEMI ولا NSTEMI, and after that developed another plaque and it was diagnosed. These patients don't do well. They're not the same as someone who never had an MI. Patients with recent plaque rupture, they have worse prognoses. And then last is the patient's general health and comorbidities. So the more comorbidities, for example, uncontrolled diabetes, uncontrolled dyslipidemia, chronic kidney disease patients, these patients in general don't do well compared to patients with less comorbidities. So going back to our case that we had earlier, so the patient had the echo. What did it show? It showed that he had the mildly dilated LV cavity and severely reduced LV systolic function. The ejection fraction was estimated to be 20 to 25%, and then there was diastolic dysfunction and moderate MR. So في الحالة هذه, after the patient had that echo, what would you do next? Would you consider doing a cardiac MRI? Would you do an exercise treadmill stress test? Would you do a stress echo? Or would you start the patient on guideline-directed heart failure therapy and then arrange for a coronary angiogram? Well, repeat the echo because the echo doesn't match the patient's clinical appearance. He looks too good to have anything. So if you go over cardiac MRI, there's no real indication to do a cardiac MRI. It's not wrong, but why would you do an MRI? First, it's not a first-line modality to check for coronary arteries. You're probably better off with coronary CT if you're looking for coronary anatomy. We still don't know why he had LV dysfunction, so I would probably not do cardiac MRI. A treadmill stress test, again, there's no application, not at this stage, with his underlying left bundle and now severe LV dysfunction. Stress echocardiogram. Again, there's no role to do a stress echo at this point. You have someone with shortness of breath, severe LV dysfunction. You want to know why. It may have utility later on after if you want to check for viability. But not now as a working test. Start the patient on medical therapy for heart failure and do a coronary angiogram. This is probably the best answer because the patient clearly has heart failure. You want to start treating them early, and then you want to define their anatomy, right? Because the most common cause for heart failure is obstructive CAD. Up to 80% of these patients have obstructive CAD. So That's the right answer. So D would be the next step in this patient. So now we're going into how to manage these patients, manage patients with stable coronary artery disease. As you can see, these 5 points are the framework of how these patients are managed. So you identify any associated diseases that can precipitate or worsen angina. For example, if someone is hypertensive, you want to make sure their blood pressure is under control to eliminate the angina, anemic, thyroid dysfunction. So anything that may precipitate the angina. Reduction of coronary risk factors, whether via pharmacological and non-pharmacological interventions. And then you have the medications or medicines to treat angina. And at the end, you have revascularization, whether it's via PCI or Cabbage. Another trivia about Ibn Sina. So since we're talking about management, he had a book out of, I think he wrote at least 450 books. Out of them, 40 were on medicine. He had a book named Kitab al-Adwa al-Qalbiyya. So it was like a specific book for cardiac medicines. He described simple and compound drug remedies, and he divided them into several categories, which included stimulants, diuretics, and cooling agents. The interesting, some of these drugs had like calcium channel blocker properties, so that's probably how these cardiac effects were derived. I find it interesting how Ibn Sina focused on cardiology. If he was a modern day doctor, he probably would have been a cardiologist, I would assume. So when we talk about managing patients with stable ischemic heart disease, you can divide the medicines into two main pathways or categories. So you have medicines to treat the angina itself. It does not have impact on survival or prognosis. It just relieves symptoms. So this is to the left side. You have beta blockers, calcium channel blockers, short-acting nitroglycerin, avabradine, long-acting nitro. And then last, you have ranolazine, nicorandil, and trimetazidine. These two are not common in the US market. I know in Europe they use it a lot, and I know in Libya as well these are used as well. And then to the right we have event prevention. So these are steps that we can take to decrease long-term cardiovascular events and improve the patient's prognosis. So starting with lifestyle management, which includes changing patients' behaviors, increasing exercise, watching diet, which I'll talk about a little bit more in the next slide, and then control of risk factors, which includes, for example, if the patient is diabetic, you have to bring down their A1C. If the patient has dyslipidemia, you have to make sure that their lipids are under control. If the patient has hypertension, you have to make sure that's under control. So these are things that would affect the patient's trajectory on the long term. And then we come to antiplatelet therapy, which includes aspirin, and statin therapy. So these are medicines that do affect and decrease cardiovascular events. This is a slide from the European guidelines. It just shows and highlights the important lifestyle recommendations. So starting with smoking, as you all know, a big chunk of our patients are smokers. And it's very, very important to stress the importance of tobacco cessation and how much risk it reduces just by stopping smoking. Also, leading a healthy diet that's high in vegetables and fruits and low in saturated fat. Physical activity is very important. So it's usually recommended to have at least 150 minutes of moderate intensity physical activity per week to decrease your cardiac events. Maintaining a healthy weight with a BMI less than 25. So these are important lifestyle recommendations that we should recommend to our patients, to decrease their event risk when they're before or even after they're diagnosed with obstructive CAD. So medical therapy, like these are medications that affect that lower event rate, specifically aspirin. You have Plavix. If the patient cannot tolerate aspirin, and the patient has either gastric ulcers, has severe sensitivities, and just cannot take aspirin for any reason, you can start the patient on Plavix, which is 75 milligrams daily. And then we have statin therapies, and the high intensity statins are what are recommended in patients who have coronary artery disease. So you have atorvastatin and you have rosuvastatin. So let's say you have a patient who is diagnosed with stable ischemic heart disease. Let's say the patient دار cath كان عنده 70 to 80%, let's say middle LAD lesion. The patient was symptomatic, and for some reason the patient was not on any medications. So by guidelines, you're supposed to make sure that they're medicated first before revascularizing them. So starting to the left, the first step, standard therapy, is starting with a beta blocker. If the patient does not tolerate a beta blocker, then a calcium channel blocker. And then on top, you have patients in different subgroups. ممكن يكون عندك patient the heart rate متاعها above 80. If that's the case, you start with a beta blocker, ولا a non-dihydropyridine calcium channel blocker, which is the cardizem ولا diltiazem ولا verapamil. These two calcium channel blockers, they lower the heart rate. If the heart rate is still not controlled on either one of them, استعملهم together. You use a beta blocker, مثل metoprolol ولا bisoprolol, with a calcium channel blocker. If the patient is still symptomatic despite being on both of them, then you add, you can consider ivabradine. If the patient's heart rate is still high, then ivabradine can lower the heart rate further. بالتالي, fourth step, if the patient is still having pain despite these changes, then you can add ranolazine, ولا nicorandil, ولا trimetazidine. And then let's say مثل patient heart rate already, patient at baseline heart rate أقل من 50. معناها بتحط عليه، مش حتقدر تحط على بيتا بلوكر، ومش حتقدر تحط عليه النون دايهيدروبيريدين كالسيوم شانل بلوكرز اللي هي الفراباميل والدلتايزم. في الحالة هذه بتحطهم على الدايهيدروبيريدين كالسيوم شانل بلوكرز. For example, عندنا الاملودوبين. لو البيشنت didn't tolerate it for some reason or not, you can put them on long-acting nitroglycerin اللي هو نقول له اندور ولا اللي هو isosorbide mononitrate. And if that doesn't work, then you add another agent, or you combine them together اللي هو calcium channel blocker with long-acting nitrate, and so forth. بالتالي fourth step, you add one of these, ranolazine or nicorandil and so forth. And then to the far right, عندك different categories. مثلا لو البيشنت عنده heart failure, the angina, طبعا beta blocker is used for both. It's used for treatment of the heart failure, and also it can treat the angina. في الحالة هذه, you follow this algorithm. You use long-acting nitro. Next step, if it doesn't work, you can add ivabradine حتى لو heart rate بدأت لو heart rate above 70, and so forth. Let's say the patient has angina and the blood pressure is always low. ففي الحالة هذه, maybe you try low-dose beta blocker with a low-dose non-dihydropyridine calcium channel blocker. If the patient didn't tolerate it for any reason, you can consider ivabradine. And the good thing about ivabradine, it does not affect the blood pressure, right? It only lowers the heart rate. And then you can add and combine agents as needed. But this is a nice, diagram that shows how you can make combinations and titrate your medications accordingly. So going back to our case, the patient underwent a cardiac catheterization after he was initiated on heart failure treatment. The Catheter Report described multivessel coronary artery disease. It describes severe, heavily calcified, diffuse proximal mid-LAD disease, severe proximal large diagonal disease. He has a large left circumflex with severe disease involving the obtuse marginals, two of his obtuse marginals, and distal left circumflex. طبعا don't look at this image. It's not representative of this patient. So don't get confused. And then last, the patient also has a CTO of his mid RCA. So the patient has severe multivessel CAD. So how are we going to proceed now in managing this patient? What's the best next step? The patient diagnosed with heart failure and severe multivessel coronary artery disease. So would you start the patient on dual antiplatelet therapy and repeat the echo in 3 months? Or consider multivessel PCI if the patient is symptomatic? Or refer the patient for Cabbage? Well, refer to a local herbal practitioner per the patient's request. I think I heard this in one of the posts. I've seen that before. That's apparently an option these days. So you have a patient with multivessel CAD, severe LV dysfunction, and coronary anatomy describing diffuse CAD everywhere, pretty much, involving all 3 major coronary arteries, including proximal LAD. So I think the answer here is straightforward, and everybody agrees that this patient you would probably refer for Cabbage because of the diffuse nature of CAD, low EF, and we'll talk more about why we would do Cabbage in this situation. So this part of the lecture, I'm going to talk about coronary revascularization in patients with stable ischemic heart disease. So in the US guidelines, for stable ischemic heart disease, there are 3 major indications. Okay, so starting from top, and the revascularization to improve survival compared to medical therapy. ففي certain situations where when you do revascularization, you actually impact outcomes of the patient, not just for symptoms, but actually hard endpoint outcomes, including mortality, MIs, and so forth. And then the second is revascularization to reduce cardiovascular events in stable ischemic heart disease compared with medical therapy. So that's another reason to do revascularization. And last, revascularization to improve symptoms. ففي الحالة هذه you're only doing it because the patient has refractory angina despite treating them with medications. So في السلايد هذه I'm bringing the European and the US guidelines. And the European guidelines to the left and the US guidelines to the right. The European guidelines had it from 2018. Well, the US guidelines is fresh off the press. This was in 2020. This is actually, I think, in the end of 2021. So starting with the European guidelines, they divided them to 4 prognoses with 4 symptoms. So these are all class 1 indications. What's 4 prognosis? لو البيشنت تلقيت عنده left main أكثر من 50%. لو البيشنت عنده proximal LAD أكثر من 50% with evidence of ischemia, whether it's by an FFR, IFR, or a nuclear stress test. Not just angiographically 50%. Don't get this wrong. There has to be evidence of ischemia in that territory. And then if the patient has 2 or 3 vessel disease, more than 50%, again, the 50% here, there are details about there has to be ischemia in that territory, whether with invasive or non-invasive testing. And if the patient has multivessel disease, EF أقل من 35, this is also another class 1 for revascularization. And another one is large area of ischemia that is detected by a stress test. لو أكثر من 10%, this is a consideration for revascularization. And then another interesting point as a class 1 is, let's say عندك patient عنده only 1 vessel left. Let's say, for example, patient عنده circumflex occluded at its beginning, and the RCA occluded at its beginning, وعندك LAD and the blockage more than 50%, let's say in the middle of it. So في الحالة هذه you have one vessel feeding the entire heart. ففي الحالة هذه they would recommend to revascularize the patient. And then the second part here is for symptoms. And then when patients عندهم hemodynamically significant stenosis and angina that is not responsive to medical therapy. في الحالة هذه you should revascularize them. So for the US guidelines, the European US in general guidelines and the US, they're very close. They're all very similar. شنو الفرق بين these two? These US guidelines, they came after a very big landmark study called ischemia trial. And based on that, and also other trials that came in between, based on that, there are some adjustments in the recommendation. So one of these differences, for example, look at the class of indication for proximal LAD stenosis. On the left side, Europeans give class 1. On the right side, stenosis in the proximal LAD for the US guidelines was downgraded to 2B. So in patients with stable ischemic heart disease, normal EF, and significant proximal LAD stenosis, the usefulness of coronary revascularization to improve survival is uncertain. This is a big change compared to prior guidelines where it was class 1. And then as you go forward here, the rest of the guidelines are the same. I think one of the other differences is here is recommendations for revascularization to reduce cardiovascular events in stable ischemic heart disease compared to medical therapy. What do they say here? They say, in patients with a stable ischemic heart disease and multivessel CAD that can be appropriate for either Cabbage or PCI, revascularization is reasonable to lower the risk for cardiovascular events such as spontaneous MI, unplanned urgent revascularization, or cardiac death. So this is also a relatively newer indication, and this probably stems out of some of the studies that looked into physiological assessment of coronary arteries and patients who were, for example, I'm talking about the FAME studies where they found that patients who were interrogated and with IFFR and stented accordingly, they did better and had less events compared to those who did not have their lesions interrogated physiologically. And then recommendations for revascularization to improve symptoms. This is similar to the European guidelines. So these are the main differences I found when comparing the US and the European guidelines when it came to revascularization in stable ischemic heart disease. So going back to our case, Alash, why did we make the decision for Cabbage? So the patients can under multivessel CAD. You can argue maybe intermediate to high syntax score, and the CTO, long occlusions, calcified, some are bifurcation. So in general, the higher the syntax score, which is for those who don't know what syntax is a scoring system that looks into coronary anatomy, and the more complicated the coronary anatomy is given a higher risk score. And in general, patients with a higher risk score, they do better with Cabbage compared to PCI. And then the patient has severe LV dysfunction. So EF is less than 35%. Again, we have data. And I think one of the famous studies on this topic is that we have the STITCH trial. So patients, and that was only comparing to medical therapy, but patients who did Cabbage compared to medical therapy with severe LV dysfunction did a lot better. And then you have patients with diabetes. In general, the notion that patients who are diabetics, they do better with Cabbage, again, based on some studies. They do better than percutaneous intervention. So because of all of this and probably other reasons, that's why it's better for this patient to have Cabbage instead of PCI or just medical therapy alone. And here again, I talk about this is the class 1 indication for our patient that I just described, where the patient has multivessel disease, is appropriate for Cabbage, severe LV dysfunction. In this case, Cabbage is recommended to improve survival. And this is from the 2021 revascularization guidelines, and it just talks about the certain pathways to take. I pretty much just went over this right now through those two tables. So remember earlier where it said, let's say the patient had workup, stress test negative, coronary CTA is negative, and they're still having symptoms that are concerned that sound like angina. So this description of or abbreviation called INOCA, I'm pretty sure a lot of you heard of it, which is ischemia and no obstructive CAD. So you'll have patients that actually are having ischemia, but it's not caused by epicardial coronary obstruction. All of these here can cause that, whether it's uncontrolled hypertension, severe aortic stenosis, microvascular dysfunction is a big one, and so forth. So always keep in mind that there are other causes of coronary ischemia besides epicardial coronary obstruction. So these all always should be in the differential. You know, once you have tested patients, had coronary angiograms, and they're still complaining of angina, always think about these other causes. And remember, stable ischemic heart disease, although it's prevalent and we can take care of it because it's easy, right? We're taking care of the epicardial coronary arteries. And believe it or not, this is only 5% of the vessels or the arteries and arterioles that are feeding the myocardium. So to the right, you have all that microvasculature that's responsible in feeding the myocardium. So a big one is microvascular dysfunction, like I said, which is a cause of ischemia and no coronary obstruction, INOCA. So always I like this picture because it reminds me that once I cath the patient and I don't find any obstructive CAD, I always think about this diagram, you know, and can it be because of other etiologies and more specifically here, microvascular dysfunction. So in summary, recognition of stable ischemic heart disease requires careful history taking. The presentation can vary. Therefore, you have to have a high index of suspicion. Management of a stable ischemic heart disease includes controlling risk factors, the use of medications, like I said earlier, either for event prevention or symptom relief. Revascularization is indicated for refractory angina not relieved by medicine or for prognosis. And when no epicardial obstructive disease is found, always keep in mind other possible etiologies of angina and the description of INOCA. And thank you. Shukran.
Barakallahu fiqh, Ali. I think that was a great job, a great summary, yeah, and very well done. So I think I'll open up the room. You can unmute yourself if you have any questions. Sam Abhiliya, shukran lahaq taji. I'm sure you were very busy. Mohammed Ayan is on the with us as well on the expert panel. I think that was you know, I had a lot of questions that I wrote down and then you answered them afterwards. So it's you know, what I really like about your talk is this is designed to be part of an interventional cardiology talk. You spent an hour going over a very important problem, but there was not, you know, without much talk about revascularization or stenting, which means, you know, we're not just plumbers. There's a lot of thought that goes into this. So, and I thought you did an excellent job there. Sorry, let me open up the.
I think I got it, Bassem. Yeah.
You got it now. Yeah, sounds good. Yeah. So you have a virtual background going on, so you look like a ghost. Actually,
yeah. I'll fix it.
I'll ask Mohammed, Ayan, you can unmute yourself. What's your ranolazine is on the drugs described, prescribed, or used for patients with uncontrolled symptoms. What is your use of that? Do you find it useful? We don't have it readily available in Canada, so I'm not very familiar with it. So I'd
السلام
like to
عليكم.
hear your experience.
السلام عليكم، اهلا وسهلا. بارك الله فيك دكتور علي، very informative talk. بالنسبه للرونالزين for me يعني نستخدمه، يعني زي ما قال دكتور علي، يعني نبدا ممكن third line، يعني نبدا في العاده بالبيتا بلوكرز او الكالسيوم شانل بلوكرز، وبعدها يعني نمشي لللونج اكتنج نيتريت، يعني الثيرد line for me is ronaldin, and it works sometimes. So it does work, يعني not 100% of time, but I think in almost maybe 6 out of 10 it works. أنا مش عارف يعني شنو أنت دكتور علي شنو your experience with ronaldin, but I think it does work.
Yeah, no, I agree with Muhammad. It's very effective, actually. And like I usually don't start early with it unless you're limited. Like I said earlier, let's say the patient's blood pressure is low, or the patient is really bradycardic, and they're on high doses of nitro already. And in that case, it's usually a second, third line agent. But in general, once you start it, it's very effective. Side effects is not uncommon. I think you probably all agree. Constipation is a big one with ranolazine. That's one of the, and GI symptoms. Those are the most frequent symptoms you usually get when starting these patients on the ranolazine.
في عندي question ليك يا علي يعني.
Yeah.
مثلا patient جاي with the stable ischemic heart disease and you start him on optical medical therapy. So what's the optimal medical therapy in your mind? What's the definition of optimal medical therapy? When in other words, yeah, when you're gonna say this guy failed the medical therapy and I would like to send him for CAT and possibly PCI?
That's a very good question, and I think that varies. So, if you're going to look into like appropriate use criteria, okay, let's say that's what guides us. They would say if they need to be on at least 2 anti-anginal agents. So putting them on 2 maximally tolerated anti-anginal agents, and if they're still having symptoms, in that case, you can proceed with your vascularization. And again, I think it really varies. It depends, right? Some patients are okay being on more than 2 medicines. Some patients are not okay. You know, if the patient is willing to take more than 2 medicines, you can put a 3rd agent. If the patient tells you, no, I'm taking too many medicines, this is too much, then in that case, you should revascularize them. You know, I think it really depends. It depends on each patient and every circumstances. But if you're looking at appropriate use criteria, it's usually at least 2. If they fail 2, then you're okay going ahead and revascularizing them for patients with stable ischemic heart disease.
And for how long would you wait before you said, oh, this patient failed the optimal medical therapy?
You mean, let's say the patient is on well, you mean after challenging, let's say the patient is on 1 medicine, maximal dose, and I start them on a 2nd medicine. I would usually bring them back, you know, and I would give them at least 2 to 4 weeks, you know, before I would make a decision, you know, whether this worked or not, you know. I'll give it some time, you know, and before I would say the patient failed the medicine or not. It's arbitrary, to be honest, but that's my own personal practice.
How about you, Beth?
Yeah, I think it as Ali put it perfectly. I mean, first of all, patients with unacceptable angina were excluded from the ischemia trial. So if their symptoms were bad, they would be excluded regardless from the ischemia trial. And the ischemia trial showed that revascularization did not improve heart outcomes, but did result into a more quicker resolution of their symptoms. If even after excluding those with patients that are not as symptomatic, So I think that shows us that revascularization is the best anti-anginal we have. It just comes with a cost, both in terms of risk and cost of for medical care. So, and I think that comes into balance with different patients. If the symptoms are not severe and they're willing to try longer with medical management, I'd try 1, 2, 3 agents. If their symptoms are acceptable, then would stop. If there's once we've ruled out significant disease, I mean left main disease, if their symptoms are unacceptable, and what's unacceptable for a 45-year-old who wants to be active is probably different than what for an 85-year-old sedentary patient, then we just continue with medical management.
Okay, thank you very much. I have another question for you, Ali. If you can put some shade about the result of ischemia trial, since it's one of the most important trial, which I think it was published back in 2019, but the final result I think was published in last year.
Yeah.
So if you just summarize the most important point and the take out point from the ischemia trial, that would be great. Thank you.
Yeah, great question. And I knew this was going to be brought up because it's a very it's a relevant trial to what I presented today. So for those who don't know what ischemia trial, it's a very large multi-central randomized trial that looked to compare coronary revascularization in patients with a stable ischemic heart disease, whether Cabbage or PCI versus medical therapy. So what they did, they randomized more than 5,000 patients. And what they did is they would say, okay, so we have patients who are confirmed to have coronary disease, whether by stress tests, and to include them, they have to show moderate or severe ischemia. And once they confirm they have moderate to severe ischemia, they would then do a coronary CT scan if their kidneys are normal or kidney function normal to exclude left main disease. If the patient did not have left main disease, then they continue with the randomization between medical therapy, PCI, or Cabbage, all accordingly. And then after that, they followed these patients up to 5 years and looked at their outcomes. And the hard endpoints included death or MI, combined endpoint of cardiovascular death and MI in over 5 years. So basically the bottom line of the study, after 5 years, they have noticed that there was no difference in these outcomes that I mentioned when comparing people who are put on medical therapy compared to people who got revascularized. That's the basics. That's the basics of this study. Obviously, there's a lot of points that we can talk about. It's open for discussion as to what are the limitations of this trial, and because there's a lot that we can talk about. But that's the basics of the study of the ischemia trial. I don't know, Bassem, if you have any more inputs about.
No, I think it's an important trial, and it does affect our guidelines, affects our management of these patients. The challenge in exporting it to daily practice is the need to exclude left main disease, which was done with CT angiograms in all the patients. And depending on what healthcare system you work in, doing that for all your ischemic heart disease patients might prove a challenge. So that's the only caveat there. أسامة بليل ما أعرفش كانت تسمع فينا. عندي ليك سؤال على الكيس اللي Ali presented. I'm sure you weren't there, but his case example was of a patient with symptoms of angina, exertional chest pain and shortness of breath, who had an EKG showing a left bundle branch block. Now the patient had poor LV systolic function and required revascularization anyways, but let's assume his LV function was normal. I mean, usually classic teaching, the best test for this would be to assess them with the nuclear scan, because most of the other modalities are not very useful in assessing ischemia. And anyone else could answer if they're not available. What's the what would your practice be in Libya, or at least in Tripoli side of things?
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.
السلام.
نعرف شو ما سمعت السؤال ولا نسمعه فيك حنيته.
آسف جدا دكتور باسم، هيك لجتني الأنا. على العموم آسف جدا على أنني خشيت متأخر الحقيقة، ونحب نشكر الدكتور علي على المحاضرة الحقيقة رغم أني ما حضرتهاش.
ما فيش مشكلة، أكيد عندك ظروفك، أنت إنسان مشغول جدا يعني.
بارك الله.
ما فيش مشكلة. عموما
لو تعود للسؤال مرات ما سمعهاش.
قلت لك يا أسامة patient has a ischemic symptoms, left bundle branch block and an overall normal echocardiogram.
الله فيك، والضي هارب يا دكتور.
ما فيش مشكلة.
تمام إن شاء الله.
العذر عند الظروف، بس يعني أيمن بكشي أنت عندك have any experience, what do you think the test availability would be there for I think someone in the comments mentioned that nuclear scans are now available, and this is a common scenario.
هو زي ما قلت يا باسم بصفة عامة يعني when you have a left bundle branch block the best test would be a nuclear، لأن أنت عارف يعني في الإكسرسايز treadmill وفي الدوبيوتامين stress echo اللي هم الكيميكال that will cause tachycardia. The purpose of this test صح يعني tachycardia، this will mislead your interpretation. لكن a lot of expert echocardiographers they still recommend to use the stress echocardiogram in patient with left bundle, okay, if the Lexis scan is not appropriate or is not available, and you just look at the thickening of the ventricular septum, not the dyskinesis, you know, because what will happen with left bundle with the tachycardia, the septum will start shuttering. So they say, no, just don't let that mislead you, okay? Look at the thickness and look at the other regions. So you, again, this is like, will be like a, option A, the Lexis scan, the nuclear stress test, like we said, and it's not exercise in nuclear stress test. It has to be a chemical with regadenoson because you want to avoid the tachycardia. And another caveat, since Dr. Rajab, he said some clinic now in Libya, they still do they start doing the nuclear stress test. Even with the nuclear stress test, pharmacological, regadenoson, if patient develop tachycardia, and that may happen, they may have an artificial attenuation defect at the septum, sparing the apex. How to differentiate with that? If you see a septal defect sparing the apex, that's probably from the left bundle branch block. But if you have a septal defect with a nuclear stress test, a chemical one, involving the apex, then you'd be very concerned about LAD. So this is kind of my input on this point. الزملاء في ليبيا they can comment يعني in those situations did they just go to cardiac CTA or heart cath لكن بس if you point I want to mention it since we have a lot of interventional cardiologists here. I think there's misconception انك انت if you send the patient to the cath lab they end up with a stent. It's intervention. You still send a lot of cases for diagnostic. طبعا now we know with the coronary CTA is going to take in a lot of volume from that, but don't think about going to the cath lab just for intervention. You still can use that for the diagnosis to reach your diagnosis. So this is important. For example, the case actually that Ali showed, the first one, that patient was high probability for coronary disease and was curious about what you guys think. I think even taking that patient to the cath lab won't be inappropriate because he's a high risk for underlying coronary disease and you want to define the coronary anatomy. So this is remember, the patient with intermediate risk, they're the best patient that you should recommend a stress test. But sometimes you can take the patient to the cath lab, okay, but if you think they have high risk features, like this is high probability of coronary disease. Thank you.
I think that's an excellent comment, Ayman. I mean, if that patient who has clear-cut CCS class 3 angina and a nuclear scan came back as reported as normal, because your pre-toss probability was so high, there's a high chance that this was a false negative. And in reality, what I'm seeing, what I advise my community cardiologists where I practice is that you have a patient like that and you want to send them to the cath lab, just make sure you start them on their anti-anginals. And then when they show up to the cath lab in a few weeks' time, they've had a few weeks of anti-anginals, and I can ask them, how's the effect on your symptoms? How's on quality of life. If the symptoms have improved, then I'll do the cath for diagnostic reasons, but they're still quite symptomatic. Then I think it would be reasonable if I find something that's readily easy to intervene, to go for PCI, or if it's more of a Cabbage patient, then refer them back to the community cardiologist for further assessment. But I think that's an excellent point. A diagnostic angiogram for risk stratification in your high chest probability, depending on what's available, is not an unreasonable question, not a reasonable approach.
By the way, Bassem, Ali, Muhammad, there's one important caveat from ischemia trial. As you know, ischemia trial, Courage trial in the 1999-2004, Barry 2 trial, all of them, they showed in stable ischemic heart disease, medical therapy versus current intervention with the PCR or Cabbage, there was no clinically significant difference in terms of major outcome like mortality, right? But if you look at all these trials, each one of them, I think Courage and Barry 2D trial was like around 2,000 something, and ischemia, like what Ali said, 5,000. But all of them, they showed those patients, they had better quality of life, less angina. So the caveat from the ischemia trial, is not the main outcome, not just to decrease mortality, not just decrease heart failure hospitalization, but also improve patient quality of life. Patient comes to us because they want to feel better. They don't tell us, I want to live longer. They don't. No, there's no patient will come to your office and say, hell, can you make me live longer?
صوتك هرب يا أيمن.
Okay. البوينت I'm saying in what ischemia trial telling us إنه the PCI is a very effective anti-anginal therapy.
That's an important, and just a reminder that the ischemia trial was a trial of revascularization, cath with a view to revascularization. Sure, not just PCI, but Cabbage as well was in there. So, but yeah, excellent. There's a few questions in the comment that in the chat that I'm just trying to go through these quickly. So Rajab Tlala asked, when would you say that medical therapy has failed? Only when one or all? I think we've discussed that already. The other question is, a late presenting STEMI management equal to CCS management? I'll pass that on to Mohammed.
I missed that second question.
The question was, is late presenting STEMI management equal to CCS management, chronic coronary syndrome management? I think that's what.
It's different. So even if you see to the ischemia trial, first of all, when it's late. So for example, in the ischemia trial, they exclude all these patients who had late ACS presentation, either non-STEMI or STEMI. So it's different in terms of the.
Yeah. So if there's other and the other part of the question is, when can you say that it's a late presenting STEMI?
It's after 7, so it's after 48 hours. It's considered late presentation, when most of the expertise actually don't recommend any intervention if the patient presented after 24 hours, and especially if there is no indicative of ongoing ischemia. So I don't know what's your practice, but usually if there's no ongoing ischemia after 24 hours, there's no recommendation to intervene, and it's considered late presentation.
Yeah, I think that's perfect. I mean, in the late presenting STEMI, if it's late presenting, that means that the infarct has been completed. So the heart muscle is dead. There's nothing there to salvage. So unless there's a good reason to say, well, the patient's still having recurrent episodes of chest pain, that's angina equivalent, or the infarct wasn't a large size based on his biomarkers, classically would say do not open up that vessel. Now, the management medically is different, because that's an indication for dual antiplatelet therapy. If there are residual non-culprit lesions, I'd still revascularize them, extrapolating from the other trials of complete revascularization post-STEMI. And the goals for your for the statins, for example, is going to be very different, and the prognosis is worse, of course.
Yeah, and the other thing, when for the late presentation, there's high risk that you might cause harm actually when you open up the artery. So you might precipitate cardiac rupture, and I have seen it once. The patient came late, and then they open up the artery, and because the tissue is friable after almost 24 hours or so, the tissue become friable, and then if you open up the artery, you might cause more the gush of the blood can cause rupture of either the septum or even the free myocardium, and it can cause disaster.
Yes, exactly. You're converting it from a white
سامحني دكتور باسم.
ايوه سامح.
هو في اضافه بسيطه حسب اليوروبيان جايد لاينز في 2019 الكرونيك كورونري سندروم اللي هو ما بين قوسين اللي تو اسمه ستيبل يخش الديفينيشن افتر 1 year اوف ذا اندكس ايفنت. يعني واحد صارت له اكيوت كورونري سندروم نقولوا ستيمي ولا نون ستيمي after 1 year he will be considered as سواء كان treated medically ولا intervention he will be considered as a chronic coronary syndrome. فالديفينيشنز بالنسبه للكرونيك كورونري سندروم بالنسبه للبوستن ماي انه يكون 1 year after the index event.
That's a good point. I think after 1 year, the early risk from
هذه في اليوروبيان جايد لاينز في 2019.
مظبوط صحيح. I think that definition is because they want to make sure. I mean, these patients have, even though their risk of events might have normalized a bit, they're still at high risk of long-term events, and they have a chronic condition that still warrants aggressive treatment. Ali, عندي لك سؤال على المedical management. You mentioned aspirin and using Plavix if patients have an allergy or intolerant to Plavix or clopidogrel. Now, would you ever use clopidogrel instead of aspirin for someone who has high risk of bleeding? That's question number one. And then second question, there's been a lot of talk in the news recently about aspirin not being appropriate for cardiac prevention. So do you have any comments on that?
Yeah, very good points. So patients, السؤال الأول اللي هم patients اللي هم high risk of bleeding, you said, do you use Plavix? Is that the question? Instead
of aspirin, yes.
Yeah. So if they're at high risk of bleeding, in general, you want to use the milder of two. You would think aspirin. The problem with aspirin is especially patients who are prone for gastric ulcers, gastric bleeds, or duodenal. They don't tolerate aspirin as well. So sometimes Plavix is better tolerated. So if we're talking about patients who have a coronary blockage and high risk of bleeding, right? They're active bleeding or.
No, let's say someone who, so for example, you have a patient who has ischemic heart disease, documented a CAD for whatever type, but not a patient that needs to be undapped. They're older in age. They have a prior lower GI bleed and moderate CKD. Usual frail patient who you're worried that the bleeding risk is a bit higher.
Yeah. So the classic teaching or data is if, let's say, someone had an event, had coronary disease, whether it's revascularized or not, but we're talking about right now, we're talking about obstructive CAD. I would have low threshold to keep them on antiplatelet therapy, whether it's Plavix or aspirin. If they're high risk of bleeding, probably more aspirin because it's a less potent, basically. So that's what I would use. But patients who don't have the diagnosis of ischemic heart disease, in that case, the use of aspirin. So these are different, right? So we're talking about the patients who don't have history. Starting aspirin as a tool for primary prevention, that's what the whole talk about aspirin not being good is. We're talking about primary prevention for events. So someone starting aspirin just to prevent an event without a diagnosis of coronary artery disease. In that case, the data more recently, especially for older patients above 75, is against starting people on aspirin just for primary prevention. But it's different comparing to patients who have established CAD. Patients who have established CAD, data have shown that when you start them in antiplatelet therapy, they have lower events over time. So if I have someone who has coronary disease, whether on coronary CTA or stress testing, or I would start them on an antiplatelet therapy, no question.
Yeah, I think that's the point, because we've had a few patients. I think that's two sides to it. We've had a few patients call us recently saying, "Oh, I saw on the news that aspirin is bad for you and should stop it." And this is a patient who's had multiple stents or previous bypass surgery, so that doesn't apply here. On the other hand, there is I think my experience in Libya visiting, there's a lot of use of aspirin for primary prevention that is probably something that needs to be revisited and practice changed there.
Yeah.
I have a question here, since we're talking about the antiplatelet. So, say for example, you decided to send your stable patient for CAD. Would you start him on dual antiplatelet before you send him, or how would you manage the antiplatelet here?
You mean after? Yeah, if they're diagnosed with, let's say, with ischemia under stress test, I would probably start them with an aspirin, at least, baby aspirin. That's
but the aspirin is we understand that we already started the patient on aspirin. So, for example, you start the patient on optimal medical therapy, and then you did the trial, and the patient failed, and then you decided to send the patient for CAT and possible BCI. Would you start him on
preload? You mean?
Yeah, preload him with the B2Y12 inhibitor, Plavix, or any other.
I would not recommend. I don't think for stable CAD. I'm not sure if there's a clear guideline to that telling you what to do, but it's probably it is not recommended to start. At least, for example, when it comes to starting patients on Efient pre and STEMIs, you're not supposed to preload these patients. It probably doesn't apply to stable coronary disease, but I don't see a reason to preload patients in stable CAD before defining their anatomy. You just may end up, causing more harm than good starting on a dual antiplatelet therapy, whether delaying a needed surgery or, if God forbids, a complication happens. I don't think you should start patients on dual antiplatelet therapy prior to a diagnostic angiogram. I don't know what others do.
Yeah, I'd agree with that. I mean, if it's something that's clearly going to be revascularized, like a CT scan that showed a RCA lesion and the patient's symptomatic, I might preload them just going into the cath lab. But other than that, it's a bit of a change of practice for me over the years, because I used to be aggressive in preloading, and I think the data is showing that's probably not the right approach.
But Bassem, your point, you already defined the coronary anatomy, صح? In case you mentioned, you know the coronary anatomy, you have a plan, you know this patient going for intervention.
Yeah.
It's different. But for stable ischemic heart disease, you shouldn't do that. Just aspirin of allergic Plavix, like Ali would say. Yeah.
هو سامحني دكتور باسم، حنحكي من another view في بعض الجايد لاينز. تقدر تبدا الدول انتي بليتلت اذا كان البيشنت عنده high probability of ischemic heart disease, even without knowing anatomy.
Prior like in the going into the cath lab, or like even as an outpatient?
لا as an outpatient تقريبا مش عارف هل هي class 2B or something like this. في اليوروبيان جايد لاينز you might، هذه طبعا تعتمد على البروبابيلتي. اذا كان البروبابيلتي is high you can start the patient on dual antiplatelet before sending the patient as an outpatient, before sending him للcath lab.
وسام ايش رايك الفولو اب on this في الجروب؟ يعني I think it would be good for discussion، صح؟
Yes. لا هي موجودة في الجايد لاينز. It's not class 2A. I think it's class 2B. يعني إذا كانت تعتقد أن your patient is high risk, you can start الدول antiplatelet without يعني as an outpatient.
بس مش الستاند البيشنت اللي stable ischemic heart disease.
نحكي على chronic coronary syndrome اللي هو ما بين قوسين stable coronary artery disease. Yes.
High risk patient that you want to see.
High risk, yes. When you think from your clinical and pre-test probability and everything, you think your patient is high risk, it's allowed for you to start to do an antiplatelet for him.
Good to know.
Interesting. Yeah, I never came across.
هي أنا ما عنديش سلايدز نتاع 2019، لكن ممكن حد من الزملاء يدير لها شيرنج اليوروبيان جايد لاينز.
Yeah, good to حطها على الجروب. I think would be good for to know.
يا ريت والله، يا ريت يا أيمن.
I have a final question back to our patient with the EF of 20, okay, and you find multivessel disease. would you recommend doing a viability study before you send the patient for Cabbage, or what would you, or just you directly send the patient regardless?
If no one would answer, I can take this question.
I think my answer would be unless the cardiac surgeon really asks for it. Otherwise, no.
Okay.
I agree.
Okay.
And actually, to me, this is a trick the cardiac surgeon used to turn the patient down.
Yeah.
But
if it's a straightforward, I never had a cardiac surgeon ask for viability if the targets are really good for bypass.
But again, if you do viability and it's the tissue is not viable. Okay.
Muhammad Bassem, I'll take this. I come across this a lot when I round on the floor when I have a first year fellow very excited about reading the guidelines with studies. I think المين study اللي I think addressed this topic. Now I'm blanking it. Stitch trial. And they find out there is no change in the outcome for patients who have viability study versus no viability study. A patient who had three-vessel disease or left main, low EF, ischemic cardiomyopathy, they went for Cabbage. Regardless if you do viability or not, the outcome is not different. I think that's what which was a larger study. It was 10 years follow-up and extended the trial up to 10 years. The data very clear, and I'll tell the fellow, let's keep the patient MP after midnight. We'll go read the Stitch trial. Tomorrow morning, if you think this is appropriate to do viability, we'll do it. If not, I want the patient to be feed the patient. If I come next morning, already start breakfast. Start smiling the fellow. I think we should follow evidence-based practice. زي ما قلت لك يعني مثل موضوع السكيما trial. I don't see it's a negative trial. I see it as a positive trial لأن it shows the efficacy of PCI to improve the outcome, to decrease the angina. We should look as the angina, the chest pain, as a major outcome. شكرا.
Yeah, it also gives us leeway not to revascularize tough lesions unless there's really good symptoms. So that's okay. Well, medical management is good, and we can tell patients that there is good evidence to support just taking pills. That blockage is not going to kill you if we don't open it up. So that's
على فكرة, this is very good point. In the past, when we have very abnormal stress tests, we panic and we send the patient to the cath lab on the same day or the next day. Now, after ischemia trial, we know we have time. Start the patient on appropriate therapy and bring him back in a few weeks, see if their symptoms improve, and you can give them the option. So this is like, I think, give us more comfort that medical therapy does work, and there's always an option for PCI. شكرا.
To the point, Muhammad, the viability. So this is a real case, by the way. Actually, although it's HIPAA, but this is actually one of us, a Libyan patient. It's a real case. So in this case, actually, because it was complicated, multiple targets, I think at least 6, he had at least 6 targets to revascularize, to achieve complete revascularization. And he also had moderate MR. Initially, we thought it could be severe. So the question was doing 6 bypasses and mitral valve replacement. So it's a big surgery. So in this case, initially the surgeon, he ordered viability without asking. He ordered himself. They ordered it. And in this case, he actually it looked like he had an infarct in his RCA territory, but the rest was viable. And obviously, his MR was downgraded even further to mild. I see that a lot with cardiac MRI. So eventually, he went to successful revascularization without touching the mitral valve. So like Eamon said, in general, the surgeons would do it in either if they think that the patient is very high risk and they're trying to stray away of doing it, or maybe to guide them which areas are they supposed to focus on and revascularize to minimize pump time, So I guess it's more for them than us. But in general, if someone has severe LV dysfunction, I refer them, especially if it's new onset, refer them to bypass.
حظنا مليح عادل طلع كان لو عليك علينا. اليوم
انا ما ادريش عليه اطلاع استغربت اني ما زال معلقش يعني لكن
لا استاذن قال عندنا هذا ميتنج فكويس
باهي كويس باهي فيش مشكله Quiz. I think there's a few small questions. We'll just try and address them quickly because of time. Usama Bzghi asked, the patient presenting with long-term angina symptoms with ischemic changes and has 2 to 3 risk factors. Do we start anti-anginal medications and see response, or just order coronary angiogram? I think we've kind of discussed this. So, but in general, you know, the main issue is ruling out left main disease. But I would always, it's never wrong to start anti-anginal medications, whether you send them for an angiogram or not. Depends on his symptoms. There's a question about INOCA. The guideline recommended approach is non-existent because we don't know much about how to treat these. We use the usual anti-anginal medications we use, but you know, I'll let people add if they has any other suggestions. But it's a frustrating disease to diagnose, a frustrating disease to treat. And I think those are most of the questions. Anything else to add before we close?
باسم احنا نقولوا مينوكا myocardial infarction with no obstructive coronary arteries. زي ما قلت انت ما فيش guidelines relatively new disease. Some people they think it's you know micro plaque rupture, small very يعني minimal microvascular disease. The presentation similar to the ACS, بس I think standard of care dual antibiotic therapy and high intensity statin to stabilize those plaque. And I'm going to share على الفايبر group very good article على الموضوع هذا. لكن في point I want to mention على هذا remember stress cardiomyopathy Takotsubo. After they identify stress cardiomyopathy Takotsubo, we start learning more about the disease. We get diagnosis more or more research. So now we know more. For the same thing, Minoka, and it's just identifying those patients or given that terminology. It's gonna help us going down the road to know more about the disease with appropriate therapy. If I think some people they think cardiology when they don't know they say this is Minoka. No, it's not. The patient they do exist. وانت يا باسم محمد وعلي you saw those patients صح in your practice صح? They come like an ACS, you CAT, you don't find major blockages صح?
Yeah, to the point, like in Inoka and Minoka, technically they're different. In Minoka it's a presentation, it mimics an MI, but Inoka is just ischemia. I know it can get a little dicey.
Like syndrome X, X, ischemia. Okay. Evidence
Inoka,
good point.
Patients اللي هم عندهم troponin, maybe positive troponins or maybe not, and even if they have positive troponins hovering, but Minoka is more a presentation like an ACS. You know, like the taco patients, they come, they have 2 series of troponin raises and then drops, or other, so they actually do distinct those two categories.
Yeah, the other thing you need to consider vasospasm too, which is another thing which can mimic both.
Ali, they both share the concept there's no major obstructive coronary arteries, but one of them shows ischemia on the functional study.
Yeah,
that you see more with the stable ischemic heart disease, and the one shows the positive troponin with an MI, صح?
Yeah, exactly. They both share the
first time I come across Inoka, صح? خلاص, good, very good to learn.
Yeah.
Learn something new.
The diagnosis of Minoka is easier because because it's a clinical diagnosis. You have an ACS presentation with the normal coronaries.
Yeah.
The Inoka is harder because we see a lot of atypical chest pain. So you have to really make sure you got a good history of angina. You have a ischemia that's positive.
Yeah.
And then there comes into it a lot of various physiologic interventional tests with different drugs to try and differentiate where the level of the microvascular dysfunction is, it vasospasm, etc. And that's not clear what the right diagnostic approach for it is. One of our colleagues used to do this, and it'll take him like an hour of different drugs and administration to come up with the diagnosis, and then you end up with this with limited data on how to manage these. So I think your point about Takotsubo is correct. I think this is becoming there's more interest in research in this area. So I think we'll know more in 5 to 10 years. But at this point, it's too early to make any guidelines or recommendations.
Just final question for you. Have you ever tested for possible coronary vasospasm?
Me myself, no, but that's part of that whole microvascular study where you inject various drugs. I can't even remember what it was.
Ergometrin.
Yeah, mimics. I think I've only done it during fellowship training, but in real life, it's probably academic centers. I would think. I don't know, Bassem, if you guys do it with your fellows, but in real life, it's it's not commonly done, I think.
Ali, I'm an academic institution. We only seen it in the major meeting conferences.
والله yeah حتى انتم خلاص بالضبط yeah. It's not very practical, and I think it's I don't know, it's just not something that people will take the time and do.
Yeah, for the coronary spasm, sometimes you see it by yourself, you engage and
the catheter صح yeah.
Yeah, but the microvascular dysfunction, it's very hard to diagnose, even with these.
With that, you need to measure coronary flow reserve. Also,
yeah.
This is stuff I've done during fellowship, but it also is time consuming, and it takes you have to have a certain equipment.
Right. I think with time, it's it's lively discussion. شكرا جميعا للحضور. شكرا علي على المحاضرة القيمة. شكرا للبانل محمد وأسامة وأيمن طبعا الجاد فاذر بتاع التوكس.
Logistical support.
ونشوفوكم ان شاء الله في الشهر الجاي النكست توك ان شاء الله. حتكون more surgical talk. عادل ديب حيتكلم على الكابج، ف looking forward to it. ويلا السلام عليكم.
السلام عليكم.
جزاك الله خير. السلام عليكم.
خلاص باسم دير ستوب على اليوتيوب.
ندير لو